Hello everyone. My name is Harry de Koning. If you haven't heard me yet today or yesterday, I'm Deputy Head of Public Health, Erasmus MC Rotterdam, and I've been working in screening evaluation for the last 30 years, that's possible, and I'm being still alive. But in this big project we were very honored to start doing evaluations on hearing and vision screening. This is called a jam session, and I thought first, what is a jam session? And I think a jam session is to improvise with instruments, I think. And indeed, with the modeling, we have about 7 different instruments, and I try to improvise. But I think before that, I really have to thank a lot of people. We really have to thank all the hearing and vision experts in this project. Without them, we couldn't fill in the expertise in the model at all. But I surely really have to thank at least these 2 people here on my left-hand side, Eveline Heinsdijk, who is a senior research fellow at my department, and Dennis van Aken, who has been instrumental in trying to get the models running, together with Jan Kik, and again, with all the help of all you hearing and screening experts. So thank you very, very much. It's one of the final sort of products of this Euscreen project, and yes, I'm really proud of it. What we have asked for this session is whether some people could try and to get some runs going, where we in fact have screening a screening proposal, and then see what happens with that screening proposal in your region or in your country. So there are at least about 10 countries or so that really did that and sent us some PDFs where we can go through to give you a bit of idea how it works. And we know there have many more people have been doing that, but if you then don't at the end click on give me the PDF, then we don't have the PDF. So what I suggest to do is to give you some of the examples where they go wrong actually, and some of the examples, of course, then that if you fix something, you get, we think, a reasonable answer. The crucial thing at the end is actually to be able to to make some comparisons, so that you think, well, should I do this program or should I do that program? And that's something you should do for yourself. Again, we will still be happy to help you out in one way or the other, but nevertheless. We got some information from Romania, Israel, Latvia, sorry, you see, which I will walk you a bit through, is my suggestion. So let's go to Romania. I think from all these people, I think especially Lisa Rubin is here. So Lisa will be able to tell a bit of her experience and her experiences. If we go to the first one, that comes from Romania. If you want to go back, we just scroll a little bit to give you a bit of idea. Just one more back, just to give you an idea what we're talking about. So basically we are using the visual acuity screening model and the screening program of that. And so yes, if you go to the results, just to give you a bit of what the idea of this modeling is, that at the end you try to have a sort of summary of what my program does. I'll go into the details a little bit more, but nevertheless you can, for instance, then have given your region, they will show you, I'll show you later, they will have like 10,000, they have about 106,287 tests, about 11,000 referrals, and then it says cases confirmed by diagnostic exam, and here it says percentage not diagnosed before age 6. That's a crucial one, of course. You do a program and you want to know how effective is my program, how many amblyopia cases in this case have I not diagnosed before age 6 as of course a crucial success factor of your program. That is why we have the first here, the major effect, some cost, and then the ratio of that. And I wanted to show you this one because here it actually says percentage not diagnosed before age 6, it says 100%. That's of course not what you want. So this says, this run leads to, I didn't prevent any amblyopia cases before age 6. You should of course never do this program, of course. I'm showing you this, of course, just to I'll show you, we go to the details, why. This is logic. The moment you run something and then you get something and you think, wow, why? So if you go further, Evelien, what did we see? Yes, almost there, yes. What did they see? So this is Romania. They said, well, we have about 180,000 infants. Life expectancy, I don't know, but that's for this case not so important. But what at that first time she or he put in, or probably didn't do anything, maybe, is it on zero if you don't fill anything in? Maybe. Anyhow, a wrong number. Exactly, there is zero amblyopia in this population, and that's why, of course, we are not going to prevent any case. 100% of the 0 cases we're not going to prevent. So this is just to give you a bit of an example. This is, of course, not how it should be, but just to show you that actually it does fit. If you do have no amblyopia in your region, then actually the model runs nicely, gets you all the costing information, but of course there's no effect. Small detail. So we go to the next book because they are actually, of course, he or she, I'm not sure.
When we got results for the number of cases that weren't diagnosed before. I wasn't sure how that was generated. Whether that is that dependent also on the percent of cases that didn't come back for the second or third screen, the coverage, and also the prevalence rate?
Correct.
I didn't understand where it was generated from.
I fully understand that we don't have everything in. So it's been how do we say it, under the hood of the car it is, but you can't often see it. So indeed, in the presentation that Evelien showed, we first try to really estimate what is the prevalence of amblyopia and the different types in time. So between we start at, in this case, do we start at year 0? Or 3, anyhow. But so indeed, the curves that you showed before, based on the observational studies, gives us the idea of, okay, there should be so many cases in your population, and you can then, for your different country, change a little bit. But so that's the basic thing. What is the incidence of the population of amblyopia? And that can be a bit bigger and a little bit lower, perhaps, but it is based on these data. And then you're right, then the second thing would be how many people come, what is then the sensitivity, how many people do I pick out, will they be referred for treatment, and how successful in treatment. So you're right, the final number actually is indeed roughly prevalence times coverage, times follow-up, times treatment success, which you're right, is all under the hood. Thank you. But true. But so if we go now, this is the correct one. Maybe you go to the amblyopia first. Sorry. So apparently here they filled in the 3% prevalence of amblyopia. Again, in fact, it does have that nice curves per type that we put in. If we then go to the results, indeed, again they have in this case 150,000 tests, 28,000 people, children referred, and actually given what they do with sensitivity, I'll come back to that in a minute, actually this program then basically says I do not find about 30% before age 6, but I do find 70% basically, and with some costing of course, and then basically you get a certain amount of cost per case detected. En de collies is helemaal net op de frontpagina, hè, geloof ik. Correct? The last part of the table, sorry Evelien. And so actually, given the estimate on quality of life that we took into account and discounting, actually it here now says we have about, the program costs in this case about 2,500 euros per QALYs gained. Huh? So taking into account how many children did I find, how successful is that treatment, I give them that quality of life loss, that utility loss, the 1% lifetime that Evelien showed, and the costing, actually then you get a range of this for this specific situation. I know it's a lot of steps. We still have to make something clear.
Can you summarize it?
Yeah, so in that sense, this is what it's being described in words. It basically says that in this situation, I have about 150,000 tests. Each test costs about €7. With my program, I refer about 28,000, 29,000 children for further follow-up. And in fact, I basically do not detect about 30% before age 6, but I do detect 70% basically before age 6. And then basically it means it costs about 4,000 per case detected, or about €2,500 per quality of life adjusted life year gained.
More questions?
Yeah. No, please, because I know.
At all in cost utility and cost effectiveness, but has there been any work that's been done on calculating the number? Because I mean, I know that they say, well, if it's $50,000 in the United States, then it's cost effective.
Yeah.
Below, more than that, throw it out.
Yeah.
But doesn't it have to be adjusted for the GDP?
Yes.
Of the country?
Yes. So sometimes.
That's all.
There is yes. So first of all, there's not a clear cut border that you say now it's not cost effective. Now it is. In general, there's almost no minister that dares to say, okay, if it's this and this number, I will not pay for it, or the health insurance. So in general sense, there is a sort of feeling what is reasonably appropriate for your country. And that's why indeed the US it's 50,000. They now debate that it should be maybe 200,000 actually. Yes, no, just to let you know. In the Netherlands, often they use the 20,000, and we are proposing that's really too low. It should something be like 35,000. The UK has nice guidelines, and the average ratio for things that they agree upon in healthcare intervention is about 35,000. So to give you about the idea. But you're right, in general, for all countries, there is the debate versus whether it's one time the domestic product, the general domestic product, or 3 times the general domestic product as a cutoff. If it's 1 time, then it's very cost effective. 3 times maybe the border or so. So that is sometimes what the WHO uses. So you're right, you could look for your own country and say, well, anything that is above the level of 3 times GDP, then you may think, well, I'm not sure. And 1 times GDP is very cost effective. So you could use that, certainly. So in general, something like, in this case, something like 2,500, that is simply cheap. If this is the correct answer, of course, but nevertheless, this is cheap. Again, just to give you an idea, for the Netherlands we have quite a different number. Again, there are some things wrong in this calculation, but just to give you an impression on how to do it, sort of, and where do you run into, and is it correct? So if you scroll a little bit further down, maybe, then actually nog verder. Kijk, so in fact, here are then the details, what they try to do. So they are actually, in this case, they're doing a preschool screening at age 16 months by an ophthalmologist. They assume a 90% test sensitivity and 83% test specificity, about 10 minutes duration of the test, and about 85% attendance rate. That's what they now use to give you a bit of impression of what they filled in, basically. Yeah.
I think it also gives the numbers of detected and how much it costs per detected child is also above that. I think when the QALYs is still also there is some insecurity, but you can go a level before that.
Yes, correct. If you're not sure about what the effects are, you can stop there.
Yeah.
In principle, I personally find that wrong because yeah, I mean, what does mean €100 per child with scoliosis being detected, for instance. I mean, your point is well taken, so I'm not going, it's really well taken, that you're right. If you don't know the consequences later on, you should somewhere stop, indeed, in fact. Then it's better to stop than assume something that is also wrong. So you're right, if you go back, you're right. So if you go back, it actually here says, indeed, these are the amounts of costs. So you need about, where are we, number? So you need about, is this probably 1 million? Cost of screening, cost of treatment. This is cost per test. The total cost 7 million or so. And you're right, the cost per case detected is 4,000. And you're right, then you still can do in your head, think, well, 4,000, and what does it mean? Well, it's probably quite okay for a child. So you're right, yes. Depends who you go with. No. So I'm sorry, I don't want to offend you at all. Maybe I should rephrase myself and say, I urge everyone to think then about those consequences and try to get the correct answer for what is next. So that's why, and again, I think there are basically only 2 big, nice studies for amblyopia and the consequences to use, and that's really, really great, because without those you indeed certainly have to stop here. But anyhow, this is how you can do it. Yeah? And so indeed, under the hood, it is the prevalence, how many people come, how many children are being referred, and how successful is then my treatment, is all underneath this. So the moment, in this case, this is screening at age 16 months. If they would fill in, let's say, if they would fill in, I get screened at age 12 years, and then the model itself then says, well, the treatment success, I have, again, lots of people maybe even detect a lot, but the treatment success is so much lower that there will be a lower effect, because that is what is under the hood is happening. Yeah.
Below that.
Yeah.
Because then you also include the treatment, but not the QALYs, so then you are 1 step further.
Yeah, okay, thanks. Yeah, that's an addition. Yeah. Yeah, helpful so far? Yeah, good. So if I may go, I'd like to go to Israel. So we had now Romania basically showing if you put something wrongly in or didn't change the zero prevalence, of course, it doesn't work. Well, the model still works. Lisa has really done a major job and sent about 10 PDFs almost. So, but we thought I'm going to at least show you 1 or 2, and then maybe you give some feedback what you found difficult or so. So just an example on neonatal hearing screening for risk babies. Next slide. So again, the same sort of structure, the number of tests, the number of tests in the second round, so in either with a different machine or a different test, then the total number is, of course, adding those up. And here it says, for instance, the percentage of substantial hearing impairment. I don't know where the cutoff here was, but thank you very much, 40 dB. It says actually here, it says, given this program, we unfortunately do not diagnose this hearing impairment in 6% of the children. And so in 94% of the children, I am, let's say, in time. Yeah, and then again, the cost per case detected. I just try to, sorry, one more back. No, that's fine. And then, this is the one. So sorry for these are, of course, no question marks, but it's Israeli. It's not being the euro. That's a wrong PDF thing. Sorry. So this is just, it says, of course, Israeli.
Well, we had a lot of trouble doing the one for risk because we don't, although we divide up, we ask for the reporting, for instance, and we have different protocols for risk and low risk and high risk, but it's the same machinery, it's the same staff, and I couldn't, you know, I have absolutely no idea of how much is dedicated to the risk,
Yeah, sure.
risk kids, and how much it's all in the same hospital.
Yeah.
So and the other problem that I had was, but that we sort of took care of, but it's not really, is that when I was doing it on these rounds, I can tell that I couldn't figure out how to get the right answers using the data that we had we do, 1 OAE, 2 OAE, well, it's if you fail the first one, and then the ABR, and I couldn't get that to work at all, which I figured out afterwards. So you see nobody in the third round, but that's because I couldn't figure out how to work it. That was just my inability to understand it. So this was very difficult for me to fill out, and I couldn't. And then for the costs of the diagnostics, which we did over again when I did it with my audiology expert together, we have a list of what things are supposed to cost and whether you separate out the doctor's visit from the test and stuff like that. What its relation is, the cost list, to what the cost actually is.
Yep. No.
Your guess is as good as mine.
Yes.
I don't know.
No, this is unfortunately well known in economic analysis that especially in healthcare, of course, that sometimes you use a costing item that you know of but that is often not the actual cost. It's a tariff or whatever.
And this doesn't have here, I'm just looking at, because it doesn't have here the treatment costs. And this is just the diagnosis cost. And the treatment cost was, I don't have a list. That's totally black box.
But again, it then would still give you a reflection of what's going on, and that if you say, well, I just pulled in now 10,000, but it could have been 100 versus 200,000, you can see what will happen and how sensitive it is. I know you don't want to do that every time, so I realize that, but then still it gives you an idea about how sensitive that part actually is. If you keep everything on, you get one PDF, you then basically have the summary table, and now you put one major cost item that you're really uncertain of, you change that, maybe times 5 or so, and then see how important it is, because sometimes it is maybe not even so important. Not every item is important. Maybe a big one, but if it's only for a couple of referred children, then. So I'm not saying that we should do that with every item because it's undoable, but sometimes you could even do so and say, well, but this is, I think, I wonder whether this is the major cost item that I need to know from anyone in my hospital, whatever, and you could actually change that, do another run, keep everything same and see, well, that's not so interesting. You see what I mean? Because then it would actually be possible that at the end, if you nog een keer de kost per laat zien. Yeah? No, okay, but nevertheless, you get a cost per case detected. Again, sorry for the question mark, that is an Israeli money, I think. And then it would say, in this case, 1.8. And now you do the other one, and it suddenly now says 1.9. You think, that's not the issue. It is an important cost item, which I'm uncertain of, but at the end, for my decision, it may perhaps not be so important. Maybe, I don't know exactly now in this case, but maybe the cost per test is much more important, or the cost of the device. So you could even play around with that. And with play around, I mean simply to wonder how important that variable or parameter is actually. So this is then an example for the NICUs. So indeed, I realized I heard you had quite some back and forth. So that's really that's really good. And so indeed, that especially disentangling issues within your hospital or within the children is simply always quite difficult. Good. Is there something else you would like to see?
Well, I don't know whether if you're going to show the other one.
Yeah. Well, we have them. So which one would you? The other one.
I have some. I just had some thoughts about what we could do with it, because I did it together with one of our most senior audiologists, who is our consultant for audiology, and we did it according to her data for her hospital. But each hospital has, I mean, when we based, you know, in terms of upkeep and all those things, and that was, you know, it turns out that they use a tremendous number of probes because the people that are doing the testing are actually these young girls that do it. You know, they're trained for a year. They do it first, you know, for their national service, and then they repeat, and they're losing probes like water. And that it might be, so I don't know whether they're actually, first of all, in terms of national, I don't know whether it's accurate, but if we did it, you know, we tried to do it, you know, when we combined the high risk data, it would be, we could actually, if we tried the hospitals to give us more accurate data, because it turned out that, I mean, I don't think that the equipment is the most expensive part of the thing, but when you collate it all together and then you weighed it, it might be.
Exactly. So in that sense, that's why I mean, you could.
It's actually an interesting tool for the hospitals to judge themselves.
It is a dashboard then, basically. Getting the feedback back, and you see, listen, we are very uncertain about this costing item, and you see how important it is. So you could use it in that way, and then just change one or two of the parameters and see the difference.
And we also have it because we never said what, I mean, the people are supposed to be trained, and it's mostly audiologists who do the second stage of the testing, but the first stage of the testing, there's a whole gamut. And it could be used to explain, to look at each one of those. I mean, it could be used as a quality tool in and of itself.
Do you know whether there was something that specific other ones that you would like to? Do you know?
The last one that I did, that I sent in.
The what? The last one?
The last one that I sent in.
The neonatal from Well Babies, maybe? Is that what you would like to see?
Which one does it say? Yeah.
Yeah? Shall we do that? Let's see whether that.
What's the date on it?
Yeah, these are the last.
That's the last.
This is the last one.
This is the last one.
This is the last
one.
Right. Yeah. So this is now the example, not the high-risk children, but this is now the Well Baby.
No, it's all the children.
Yeah, exactly. Yeah, okay,
it's all the children,
sorry, all children,
and then I weighted it.
Yes, okay, that's good.
You know, I mean, I weighted it, I estimated to a certain degree, and then looked at our data according to the data that we had, and tried to weight it when I put it in.
So then it would be something like 170,000 first tests for almost 5,000 second tests. About.
Oh no, this is just Well Babies. If it's
169,000,
it's just Well Babies.
This is Well Babies.
Because I did it afterwards on all the babies, I think.
Yeah, okay. And then here we see in the this is the Well Babies. Then here it says 50% not diagnosed before age 1. Cost per case detected 34,000 Israeli money, I think. Cost per test 14. Misschien ga je, als je even naar het programma gaat, misschien dan kunnen zien wat er was aangenomen. So this was now, in this case, the example that was filled in. Age 1 in this case is, what is meant with the 1 is day 1?
Day 1.
Yeah, day 1. Yes. Day 1 OIA, day 2 AABR.
Right.
Dedicated screener technician, 95% sensitivity, 5 minutes duration, 95% sensitivity, 10 minutes duration. And this is the 85% coverage or attendance for follow-up investigations, for diagnostic procedures. And as an example, 85 OA devices needed, 34 AABR devices in this. No, again. We are happy to work further on that. Yeah.
What you put in on this page is really what is then gives the outcome.
True.
Because if you have the attendance rate, if that is low, you will have a lot of children that are not detected before 1 year of age. That affects that number. And for the duration, time of the tests and the specificity will affect the cost very much. So I did some different runs for put in different figures.
Yeah. Yeah, no, you're completely right.
I didn't send them specifically. I thought you have them, but
yeah. So I wanted to sort of show the sort of final results, and often you then, of course, have to look carefully and think, hey, can this be okay? But you're right. All the details on what you are going to implement and therefore have as an effect is primarily in this one. Huh? It's about indeed sensitivity, specificity. If you know order referral rates. Here is the profession and therefore salary cost at some point, the devices, the timing indeed, and again the 85% here means follow-up investigations for referred children is what it's meant to say. I
think I was really surprised first time when I saw so many, I have this good program and so many weren't diagnosed. And then I realized if you have like 95 for 4 several steps, consecutive steps, that will have a great impact on the number of children not diagnosed.
Exactly.
Yeah, I've got this question a lot of times. So, and each time the answer also, if you multiply all those things, then you get this answer. Yeah.
I think it is also a good example why initially the results for Albania, I think, were. Let's say, well, at first look maybe also counterintuitive, because it was about what happens in each step, and if there's too low coverage or too much loss of follow-up, that really multiplies, and then of course with successful treatment, of course. So it's crucial that a couple of percent makes a difference. Yeah.
Something I think that many people, if they don't have really been working with the screening program, they underestimate the time for doing a test. And I also thought about that for the vision screening programs, that, I mean, doing just the test, doing the OAE, takes less than 30 seconds, but you have to go there, you have to put the probes in the ear, and you have to find the child, and there are so many things around it that it takes, I mean, so many more times than just doing the test. If you have a row of babies lined up before you, you can do it very quickly, but that's not the situation.
Exactly. It's every screening program, every new cancer screening program, every new screening program, every healthcare intervention, of course, anyone says, oh, I can do this in 3 minutes or so, and then you say, yeah, in the ideal situation, that specific child or so, but it's the whole process.
You have to have the people in place, and some babies not there at that time because they have gone for some other visit with the doctor, they come back later.
So it's a good example why we have always said for the vision screening, or initially, let's say, when we thought it was effective, having screens at early ages, we have always said, yeah, but in a running program of well-baby clinics, adding this, it's a relatively easy part. Mm-hmm. So, and we did really with timesheets and so, and then it appeared, no, it's in time. It's not so important if you have already an existing program, of course, of something. So that's why we take that into account. Are you going to have a new situation, or are you adding it to something that really makes it?
But is that is also in this? You can say if it was together with some heel prick or some other test or just other, does it affect the calculation in the model? If it's a separate visit or if it is together with something?
Yeah, so what you fill out here doesn't matter for the model, but it's more to let you think about the duration of the test, or which professional or the attendance, because that all matters whether you combine it with other screening or not.
So if it says birth heel prick to the left, or if it just says other test occasion, it makes a difference in the calculation.
Yeah, no, it doesn't give a different calculation. It's just to for your own administration and thoughts what you should fill out in the line there.
Mm-hmm.
So it maybe should, but
so
in the visual acuity screening, we do take into account the duration, or not?
Yeah, we do take into account the duration.
Yeah, then we take into account duration. In the costing. Yeah, okay. So at least this is a bit how it works, and again, I know the experience is of course always that the first time you do this, you have to have the interaction, and then these are often not the correct answers yet, but that's fine. It just gives you, and you can make comparisons. So if you make a mistake with something, again, make the comparison with another program. You probably make the same mistake, but nevertheless, you know how they compare. That's the I think that's the goal and the strength of these kind of things. And of course, also comparing, in this case, comparing hearing with visual acuity screening or so is really also helpful to that, in that extent. Shall we maybe do, yeah?
Maybe it's a little strange question, but if you think to implement or set up other screening programs, not for vision, not for hearing, do you think about the same principles apply? I think yes, but
yes.
What's your opinion?
Yes, my answer would be yes.
Okay.
So, and as you may know, I'm biased. We have started with these kind of programs in breast cancer screening first and cervical cancer screening first, and the idea is simply to get the best estimate of the natural history of the disease or the risk factor or whatever. And surely, therefore, you need good quality data, you need possibly trials, you need observational cohorts. But the idea is indeed, if you get the best guess of how your disease or risk factor works, and what screening does on it, that's basically, and whether one screen or 2 screens or 6 screens. So that is why I really think, again, you need, it is not cancer, that's a little clear about that, but to get these expertise from hearing and vision screening experts, then you can make a reasonable model about, in this case, again, the natural history of amblyopia or development, maybe should I say. So I would believe that indeed that a hip disorder or something else, or language delay, I did a big trial on language delays in children, could be done the same way.
Yeah, because I was, not anymore now, but I was involved in Flanders in yes or no setting up the pulse oximetry screening for babies.
The what? Sorry, the
pulse oximetry screening, so
yeah.
saturation measurement
Yeah.
in a certain window after birth,
Yep.
To detect children with a critical congenital heart disease.
Yep.
And okay, your model was not there.
No.
But I'm wondering, it would be interesting to see those who have chosen for it, if it's, if you can test it with this model as well. Would be great to see.
Would be great.
Because some countries apply it, some don't. So, okay.
Yeah, and so again, I mean, the idea is also you can also show what you should not do. So we there was screening for scoliosis in many well baby clinics. There was almost no data around. There was no trial. There is one brace trial, one treatment trial now in the US, which gives some indications. So you can do then this kind of model and basically show that you should not do it also. It can go both ways actually. So yeah, just to give you an idea, we now have these models for I think 10 cancers. We have it for cardiovascular disease. The hearing and the vision is really new. And yeah, we think it helps. And it's not easy, I mean, but that's fine. So maybe yes, good. Maybe we go. Shall we? Was another question? Otherwise, we'll go to Letland. To the first one now. To give you again a bit of idea. Visual acuity screening for Latvia. And this is then the first result. Let's see where that is. The cost per case, yeah. So here, thanks. So again, filled in numbers. They thought the number of tests, number of referrals. Here they had as a result percentage not diagnosed before age 6 about 50% or so. So, and we'll see so in a minute probably why. But if you then just go to cost per test, 32 is already quite something, of course, I think. And then it says, indeed, cost per case detected, 12,000. That's quite huge for this. If you've seen runs and so on, and you know a bit what's going on, then the first thing you see is 12,500. 32 is already quite a lot, but 12,500. So if you go on, then we, of course, spotted what the idea was. So here they did, again, what was the NOAA career?
Yeah, that is not combined with other screening. Yeah.
So they did 2 things at age 36 and age 72. But here you see, for instance, the duration of the test, 40 and 30 minutes is what they put in. I don't know why, it doesn't matter so much, but that does have an effect on the costing.
Yeah. Optometric examination. That was my question yesterday. That an optometric examination may take 20 or 30 minutes to do a full exam.
Okay, so that's, but then it's important to sort of realize that and compare that with other things you get in that says, oh, it can be very cost effective or much cheaper. And in fact, if we go to the last one maybe, apparently one way or the other they did change it, and we didn't have, did you have feedback to them? No, I think they did it themselves.
Yeah.
But this is a good point. Welke was het dan ook weer? But actually in this one they also sent a PDF in which now cost per case detected is 2,500 instead of the 12,000. And if you go further now they did say the 20 minutes. Again, maybe the one is the correct one, is what they're doing at the moment, and they wanted to see what happens if this amount, if this time and therefore cost really changes, how much does it matter? So this is an example of what we maybe debated in the beginning. So here you see how that then basically immediately influences the results. Do we know how? Yeah, here it says 100% sensitive specificity. So do we know why they are relatively? Where is the? Yeah, disease. Oh, here now they have 26% not diagnosed before age 6, and in the early one they had 56% or so.
Yeah.
And then they probably had real different numbers here. Then I presume.
Yeah.
So. Again, just to show you that it sort of works, that then if you change something because maybe, so in this case, that's a good point, maybe they try to see what would be my optimal situation, 100% sensitive specificity, not the 40 minutes.
So the discussion is that if you have a full optometric examination, it's more expensive, it takes more time, but you reach very high specificity and sensitivity.
Yeah, exactly.
And they have no orthoptist yet.
Exactly.
So that makes lots of difference.
Good point. So that's the comparison then you can make. What is then now here my cost per case detected? Am I fine with that? Indeed, I find more cases. This is the difference indeed. Nog een keer, hier, dit was de 26% denk ik. Hè?
Ja.
Again, the result here was 26% not diagnosed before age 6, whereas in the other one we had something like 52% probably. Misschien dat we toch nog een keer naar die gaan, naar de vorige. Mag dat? Kan dat nog? Because then we can see actually what they filled in that. So here you see indeed 54%. And this is what they filled in. Only you think, or did they do something different here?
Yeah, so I don't see here in the PDF the attendance at diagnostics. I don't see the attendance to diagnostics here in the PDF. So maybe they filled out something.
They must have done something there probably, but we can check. Yeah, nice. Yeah, so it's a nice example. Okay, we have that situation. It's true. We're doing it then probably very, very good. Probably a bit expensive. But this is then my ratio. If I'm fine with that ratio, then I basically have more children detected earlier with more success at a reasonable cost. So that's how you can compare then the programs itself. Yeah, thanks. Good.
We have a question in the chat.
Very good, very good.
Yeah.
Do we know what the question is?
From Zia, and I think she can ask it herself.
Oh, okay. Let's try that.
I'm sorry, I tried to ask and I thought that nobody heard me, so Dennis asked me. Now the question that I wanted to ask is that when do we choose test specificity and when do we choose expected referral rate? Because I found that confusing. Because expected referral rate is an outcome anticipation, while the other one would be the test per se that we choose. So when would we do that?
Yeah, thanks. So do you know her name exactly, yeah?
Zia Chowdhury from New Delhi, in India.
Yeah, thank you very much. And your question, I think, was about either the specificity or the referral rate and false positives, I think, correct?
Yes, that is it. When do we choose that in the model?
So I know, and I have no verdict on it, but I know we have been debating that for 2 years now. The point is basically in the model we can use both, and they come up with finally the same answer. So if you know the one or the other, you can work with that in the model. The point is, you're right, specificity is often a very important test performance characteristic, but often people don't know it. So how do you know what the specificity is? Then you really have to make a 2x2 table and know how many people did I refer, how many were, etc., and what happened in the next year or so. So often people then just put a number on it. So I'm not saying that you are doing that, of course. Let's be clear about that. But sometimes then people say, well, it's probably 95% or so, and we can use that then, because if you don't have anything else, and you know from other programs they say it's 95%, we really can use that. But on the other hand, you could say, well, often you have a cohort or you have a screening program, and I know how many people were referred, or how many children were being referred, and how many were true positive and false positive. So sometimes people actually know that number quite well. And again, we can use that both. Correct?
I sent my PDF. I sent it with the expected referral rate because I found it very difficult to determine specificity.
Yes,
that's the reason I asked this question. So I did it with that.
No, correct. So, and again, true, if you have good high quality data, of course, you can calculate them all. So then you often do know the referral rate, the false positives, true positives, and then you can make your 2x2 table. But if you know the prevalence, you have to have an assumption on your prevalence, of course, too. But therefore, we have a nice paper now. So thank you for this question, because you're right. It sounds often easier than said. Yeah. So thank you for the question. Yeah.
Thank you, Dr.
Good. Other questions? Were there things you were really missing or so? That's silence is good. With this question, silence is good. Good. Nothing else in the chat dan nu, Dennis? Evelien? Wat? Niet? No. Evelien, had je nog dingetjes samengevat?
No. We had done the 4 we selected.
Yeah. Okay. So yeah, if not, I think I had never done a jam session, but now I have. So thanks, Huip. Thanks, Huip. And thank you. Ga jij afsluiten waarschijnlijk, hè? Met jou.
Okay, dan hou ik hem wel zo vast. So, I think we have now reached the end of the Congress, is that correct? Or are there other programs? No, huh? So, I think we really had a good meeting. Of course, because of the COVID restrictions, many people did not come. I got a lot of emails of people who were really sorry that they did not come, especially from orange countries. And now we have several people in, not only in orange dress, but also from orange country. And they tell us all that they had no problem with the customs at all. But we did not know beforehand. For instance, people from Turkey absolutely wanted to come, and it is a pity. But on the other hand, if the Congress would have been held last Thursday and Friday as originally planned, we could not even have had this meeting, because we were then limited to 30 people with far more regulations. And fortunately for us, the regulations changed last Saturday. So that is very fortunate. Also, there have been a lot of people watching on the internet, and all the sessions can be viewed again, and also the concert by Nora Dudec and by Anna Lachey and by our star recorder player, old music, Evelien Heinsteg. It can all be downloaded in DVD quality. And now I must please stand up, Dennis. There is one, and the boys at the back, can they come forward?
I think so.
Yes. Yes?
Working now.
They're working.
Yeah.
Oh, you're a slave driver, just like I am. But this is really what this man has done for us, the internet broadcast, the development of the model, the development of the website, the development of the database. And I was really, you know, I tell you what my secret idea was. I mean, I was so busy I couldn't do, you know, I wanted to do a procedure with a doctorate and put the robe and the hat, but because that's really worth it. But what you have done for the study, the way you have collaborated with Evelien, was really fantastic. I think we should give one special applause just for you.
It was my pleasure. Thank you.
And there are 4 boys in the back, and they are absolutely fantastic. They did really all the work, and it was absolutely gorgeous what they did. It was very fortunate that we could take them to the Congress dinner, and all of them climbed up in the windmill of my grandfather, which they really enjoyed tremendously. I think when the meeting is over, go at the back and don't shake hands, but thank them because they did a fantastic work. But so many other people, I mean, Mandy Nordman and Jan Kik are still calculating the expense claims, which have all to be finished tomorrow afternoon. So many people contributed, all the country representatives who really enthusiastically supported filling out questionnaires, reporting back and forth. I mean, it has been a wonderful collaborative effort. And in some respects, the corona pandemic even was favorable for the study because we have far more web meetings. So that really helped in the speed of development of the model. That really helped. Yes, that really helped in some respect. What we have not discussed is the manual for implementation of screening programs. What we had envisioned, should we have had 70 people here as originally planned, is that we would have a roundtable session discussing the manual for implementation of screening program. And it is a booklet, a PDF that can be downloaded with 11 chapters telling you exactly what you should do if you would implement a new screening program. And that also has been much work, especially by Jan Kik, who is really the great editor behind the scenes who collated the whole book. So I thank you very much, and there will be no other meeting after this. But the model will be 4 years online, the manual will be 4 years online, and all the recordings of the meeting will be 4 years online. Thank you very much for coming.